Welcome to RUMC Connections. Welcome back to RUMC Connections. I'm your host, Meredith Gaskins, and in honor of Breast Cancer Awareness Month, we are continuing our special series on advancements in breast care. So in our last episode, we introduced you to Dr. Arthy Yoga, RUMC's new breast oncoplastic surgeon, and we explored oncoplastic surgery, what it is, and how it works. So today we're going to shift our focus to what happens next, which is life after surgery. And for many patients, the journey doesn't end once the cancer is removed. It's, about healing, rebuilding confidence, and looking toward the future and hope. So Dr. Yoga will help us understand what this recovery looks like, how women can regain quality of life after surgery, and what exciting new innovations are shaping the future of breast cancer treatment. So we'll also touch on why prevention and early detection remain the most powerful tools we have, and how RUMC's Breast and Imaging Center at 1161 Victory Boulevard is here for our community every step of the way. So we had a very informative episode last, and, let's jump into things. What would you say is a typical physical recovery timeline after oncoplastic surgery?
Yeah, after a lumpectomy and oncoplastic surgery, typically it takes about 2 weeks to recover. It could be longer depending on, how the patient's doing. But as I mentioned at the last episode, sometimes they feel great. They have no pain and they're like ready to go to work 2 days later.
Love it.
And I'm like, no.
Gotta heal a little bit.
Yeah, give it some time. So typically I like, about 2 weeks of, reduced activity, taking it easy. I'm like, this is your time to rest. And then, we'll see how they're doing in their post-op appointment and let them go. But we don't necessarily let them go because I do see them regularly for about 5 years. So that recovery period, after the recovery period, we do follow them closely. We make sure that they are following up with mammograms. They do get a breast exam. Survivorship is very important, and surveillance is very important.
Of course. And I'm sure that you deal over the years, with these patients, even post-surgery, with anxiety and just, with the cancer returning. How do you help ease patients?
Yeah,
After?
so even when we first go over, what this cancer means when someone is newly diagnosed, we go over what their chances of recurrence are. We talk about, the different types of cancers, the risk with each cancer based on their biomarkers. These tell us the biology of the cancer. So a lot of women are diagnosed with estrogen positive, HER2 negative disease, which typically is a little bit easier to treat, not as aggressive. From their first appointment, they're kind of understanding what type of cancer they have. If they have a more aggressive cancer, like a triple negative cancer or HER2 positive cancer, we do have great treatments recently, and those patients are doing well. So after they're done with their cancer surgery, we're still following them for additional treatments. So they may be getting chemotherapy, they may be getting endocrine therapy, they may be getting radiation therapy. So after surgery, there may be some adjuvant therapy. That's what that's called. Treatment after surgery is called adjuvant therapy that they're getting. A lot of the patients, it's a pill that they take once a day. And they follow with an oncologist, a medical oncologist who prescribes that medication. They do some testing during that period of time to make sure that they're tolerating the medication, that they're not having any side effects from the medication. We do mammograms to make sure that there's nothing on their imaging that's showing a recurrence. So they're reassured every time they come back and get these tests. And the risk of recurrence, like I said, if it's an aggressive cancer, the risk of recurrence is high, but that means we treat them aggressively and they're getting more treatment and we're watching them very closely.
Okay. And then that post-surgery daily medication that you mentioned, is that to suppress the new growth of anything, or what exactly
So
does that do?
it endocrine therapy is what I was talking about. So it reduces the chance of cancer coming back.
Okay.
So that's why we recommend that. Another thing that can reduce the chance of cancer recurrence is actually having a lower BMI. So
Hmm.
if, someone had a higher BMI, we would talk about that as well.
Of course. And I mean, do you think that that's a contributing factor to a rise in breast cancer across the country, this sedentary lifestyle? Everybody is working in offices for so many hours. They're sedentary. They're not getting the movement that they necessarily should be.
Having a higher BMI is a risk factor for developing breast cancer.
How do you manage, scarring and cosmetic outcomes so patients feel confident in their appearance with this type of surgery?
As far as scarring, we try to make the incision where it's as hidden as possible,
Hmm.
depending on where the cancer is.
Okay.
So that's one thing that can hide it. Usually, when they have this type of surgery, I tell them, with a bra on, it's pretty well hidden. Most people heal pretty well, but if they don't, if they're having, hypertrophic scarring or keloiding, that sort of thing, we can always have them see plastic surgery,
Hmm.
do scar revision. Sometimes some injections can
Oh.
help, but most people, they heal pretty well. The scars fade, and they're able to go on with their lives and not think about it every day.
What would you say some of the biggest emotional concerns that patients share with you before and after surgery?
A lot of the times, it's a lot of anxiety in the beginning. I always ask, it's one of my questions, are you feeling anxious or depressed? And they're like, of course, so that's always the first answer that I get. But when I see them afterwards and I see them for a long time and I ask them the same questions, they're like, yeah, not anymore.
Wow.
So,
That's amazing.
it comes with it comes with the territory. I tell them, I reassure them it's okay to feel anxious, upset, depressed. Sometimes, it can be debilitating for some people.
Mhm.
And if it is, we encourage them to see a therapist, to see a psychiatrist if it's really difficult for them to get through their day to day. Because I tell them this is not forever. This is for now. And, if you've never taken any medication for it, that's fine. You're not going to be on it forever. You
Mhm.
need something right now to kind of help move through the process because don't want to become catatonic and not be able to make decisions because you do need to move forward.
Mhm.
Give them the support they need at that time, and a lot of the times they're doing great afterwards. They're surviving, thriving, and they're wanting to help other people going through this.
Mhm.
So. Yeah, even patients that I've had who've had really bad disease to begin with. I had a patient she had very advanced disease. It was HER2 positive. It was coming through her skin.
Oh
It
boy.
was it was a lot for her in the beginning, but she, took charge of her life, did what she needed to do, got all of the treatment. She had surgery, treatments afterwards, and she was really happy to be alive, to be able to be there for her family. So a lot of the times, it can be something like a turning point for a
Mhm.
lot of people that, they can really take this thing that they weren't expecting, really put them through a lot of pressure, but come out the other side. So, I'm really happy to be there for them for that period of time and to see them doing so well afterwards.
Of course, and that must be rewarding for you to
Absolutely. And that's
still.
one of the reasons, I love being a breast surgeon.
So let's talk about what role family and caregivers play in recovery.
Yeah, absolutely. Having support is everything, A lot of the times patients when they come for their appointments, they come with a family member. We encourage that. A lot of the times they may not be hearing everything that we're saying because,
It's a
with a
lot.
new diagnosis, you're running through all the things in your own mind and you may ask the questions but you're not listening to the answers. So a lot of the times they do come with family member or a friend or someone from church. We welcome that and they take notes and they're able to go back and kind of answer those questions. A lot of the patients nowadays are very educated and informed and they may even like look up all of their treatments beforehand and that's fine, but I'm able to go over everything with them, answer their questions.
Mhm.
So And we get all sorts of different level of involvement, even after recovery, after surgery, as you mentioned, in that 2 week period when they're recovering after surgery. Very important to have family help, friends help. Having meals prepared beforehand so you're not worried about that. Someone to walk your dog or
Mm-hmm.
that sort of thing. Organizations that can help if someone does not really have a lot of help. A lot of church organizations help
Okay.
with those sorts of things. But yeah, I mean, they can really build you up having family. I've seen patients who kind of want to keep everything to themselves and put on a strong front, but then they have family that say it's okay. You don't have to be so strong. We're here to pick up the pieces, that sort of thing. So, it's a very emotional time. It can be a difficult time, but it's not permanent. I always say this is temporary.
Mm-hmm.
You're going to be on the other side.
Do you find that women approach maybe recovery differently depending on their age or their stage of life?
I mean, women in general, I think, they want to do everything, and
Yes.
and a lot of the times we're like, no, 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 like take it easy. That's what I see. I think women in all stages are like that. Whether you have kids, you have work, you're like running after that, or if you're a grandparent, you have grandkids, you're running after that. So yeah, I think women just want to do everything as much as they can all the
Mhm.
time, and my job is to tell them, "No, no, no. Let your
Slow
husband, your
down.
friend, your kids, someone else do it for this period of time, and then you can go back to all of that."
Yeah. Okay, great. Would you say that there are any, long-term lifestyle changes that patients need to make after this type of surgery?
As I mentioned before, having a lower BMI can help reduce the chance of developing breast cancer again. So we do discuss that with patients. Recently, they've shown that alcohol could be associated
Hmm.
with breast cancer. There was some research that came out that said, permanent hair dye could be associated. So
Really?
there's so many things that, I think over time we're going to find out about breast cancer. But in general, I think going through something like this, a lot of people do change their diet, do want to have a healthier lifestyle. And remember, the most common cause of death in women is cardiovascular disease. It's
Mm.
not cancer. So, having a healthy lifestyle, exercising regularly, eating healthy, is going to prolong life.
When it comes to a healthy diet, do you recommend like Mediterranean type diet? What do you recommend to patients?
I mean, that's what I like. I think that's a great diet. Whatever is, available to you,
Hmm.
just be mindful. I think that's
Yeah.
that's that's the best way to look at it. Be mindful of what you're eating, how are you feeling. There was some recent news that came out saying having more processed food, gives you a higher chance of
Mhm.
migraines, of feeling sluggish, not feeling like yourself. So if something that you're eating or consuming is not making you feel well, not feeling like you're at your best,
Mhm.
maybe kind of change that.
And how much activity do you recommend to your patients on a daily basis?
Yeah, I mean, I think, in general, it's recommended 2 to 3 times a week,
Mhm.
having some activity. But in this day and age where everyone is working, it's difficult to find that time to carve out to do something. But just walking with your family or, going swimming or something in the
Mhm.
summer, just doing something and just being aware of that as well. Maybe you can take the stairs instead of taking the elevator today, or maybe park your car a little bit farther,
Get a
walk a
little
little
longer
bit.
walk. Of course, the small things that add up and make a difference at the end of the
Right,
day.
exactly. Just be mindful of, the things that you're doing.
Okay. Now, um, How do you, follow-up care and, surveillance work after oncoplastic procedures? How long is it 5 years, like you mentioned before, that they'll continue to
Yeah.
see you?
Yeah. Typically, we follow them for 5 years. I see them every 6 months for the first 2 years and then every year for the next three.
Okay.
We do mammograms every year, but typically after a lumpectomy, oncoplastic surgery, typically we do them 6 months later and then we go to a year. So we have a schedule, we try to coordinate it with everything else that they're having. If they're
Mhm.
having some other treatment, sometimes mammogram can be painful to be done, soon after radiation. So we might move the schedule a little bit. General mammogram every year. We see them quite often every 6 months for the first 2 years, and then kind of spread that out. And that's my schedule. But
Mhm.
if they're seeing a medical oncologist, they'll be on their schedule,
Got it.
and then
Okay.
a radiation oncologist. So lots of doctors, we're all on top of you in the beginning, and then slowly we let them go.
Off. Okay. It's good. Better to be on top of things. I know we touched on this in the last episode, but I know that genetics do play a role in risk. So can you explain how genetic testing like BRCA or other mutations can guide long-term prevention and survivorship planning?
Sure. So even if someone is not diagnosed with breast cancer, but they have high risk, so someone in the family was diagnosed with cancer early, less than 40, um, or there's multiple people in the family that were diagnosed with
Mm-hmm.
cancer, a male diagnosed with breast cancer, ovarian cancer in the family. All of these things kind of, give us like these red flags, like we need to look into the genetics for this person and we can do genetic testing. Usually it's a panel, 70 different genes in one of the panels that we use. And they're going to test for not just BRCA and breast cancer related genes. It also tests for colon cancer genes. It can pick up things that could be associated with ovarian cancer or prostate cancer in men. All these gene panels tell us, what is the risk, but it doesn't necessarily say that you're going to have cancer. So the risk of getting cancer. So having a BRCA mutation, which is the one that we know very well, can take your risk. The average person's risk is about 12% of developing cancer. But with the BRCA mutation, it can go up to 60 to 80%. So that's a big jump. So if someone's diagnosed with that type of cancer, type of mutation, then we look at, what do they want to do? Do they want to go ahead and have their breast tissue removed? And there's also a risk of ovarian cancer. They're going to have their ovaries removed. So we work with GYN oncologists as well. So we look at all the risks that they would have with that particular mutation and tailor it to, how old they are, when is a good time to have this surgery. So we do that for someone without cancer
Okay.
and just a mutation. If they have cancer, so someone new that's been diagnosed that comes to see me, I usually offer genetic testing to everyone that's diagnosed with breast cancer. So then we do genetic testing if they're willing to do that. Sometimes I have patients who don't want to know. They don't want to know. But most of the time they want to know. And we
Mm-hmm.
do the test and I tell them most of the time your results are going to be negative. 95% of the time you're not going to have a mutation.
Mm-hmm.
Because most breast cancers are sporadic. It's not related to a mutation. It's not necessarily related to family history. It's something new that's happened in that person, not been passed down. We do the test. If they came back positive, that could mean, depending on the type of cancer they have as well, prophylactic surgery is recommended for someone with breast cancer. Prophylactic surgery on the other side, so removing both breasts, is recommended if they have a high risk mutation like a BRCA2 mutation, BRCA1 mutation. We'll talk about reconstruction, what type of recovery they would have, but also with certain types of cancers and BRCA mutations, they can be eligible for additional treatment, additional chemotherapy. So we look at that as well. And then as far as surveillance, if they've had a mastectomy, typically they wouldn't get a mammogram afterwards because there's no breast tissue to be evaluated.
Mm-hmm.
But we would do clinical exams and follow them for about 5 years.
Okay.
So it does significantly reduce their chance of cancer coming back because we've removed the tissue.
Mm-hmm. If they did go on to, have reconstructive surgery after a mastectomy, would you continue to get mammograms or no, because it's a different type of tissue that I guess is being used along with an implant?
Right. If there's an implant, it's just going to show an implant, so that's
Mhm.
not going to help
Yeah.
looking at an implant on a mammogram.
Mhm.
If they've had a flap where they've, moved tissue from their belly up to their breast, again, it's not
Still a
breast
different tissue.
tissue.
Yeah.
So the mammograms typically don't help. But,
Okay.
Sometimes we can feel lumps and bumps after surgery, a few years later. If we feel something, then we can do other testing, like an ultrasound can be helpful.
Mhm.
An MRI can be helpful. In some cases, we may even do a mammogram if we're looking at some other tissue but it's not typically useful.
Mm.
Yeah.
And if a woman, say, has ovarian cancer, does that elevate the risk of breast cancer developing?
It certainly tells us that, there might be a genetic component and we may get, genetic testing to see if they have a mutation.
Are there risks of recurrence, and how do you help patients navigate that concern?
Yeah. So with breast cancer, yes, there's a risk of recurrence. But as I mentioned, when it's caught early, they have the treatment, the risk of recurrence is pretty low. But that's why we follow. If someone's had a lumpectomy and they have a recurrence later on, what they would have is a mastectomy is the next step if they've had radiation. So if it's a local recurrence, meaning in the breast, a lot of the times they'll just go for another additional surgery. And depending on the type of cancer, they may get additional treatment. So it's still controlled disease.
Mhm.
Now, if they have a distant recurrence, like a metastasis, like stage 4 disease, it's a little bit different. So in that case, we want to take a look at the whole body to see if there are lesions, where are they? How can they be treated? A lot of the times they're going to follow with the medical oncologist who's going to put them on systemic treatment. So, treatment that affects the whole body, like chemotherapy, immunotherapy, even endocrine therapy with
Mhm.
additional agents. Even with stage 4 disease, there's still, newer treatments that are becoming more and more available now, new research. So, it still can be treated as a manageable condition. And maybe there's no cure per se, but it's not a death sentence. You're still managing it like a long-term disease, like a chronic disease.
And how do things like age impact, a woman's likelihood of developing breast cancer? Like, does the body become more susceptible after you go through menopause, or are you more susceptible at a younger age? Does that impact?
So if we look at data, the risk of breast cancer goes up after about 30, but not significantly. Like it peaks around like 60, 70. Those types of breast cancers are the estrogen positive, HER2 negative, I would say. When we see younger women with breast cancer, it could be more patients that have the more aggressive disease. They're, the triple
Okay.
negative, the HER2 positive. There's some cultural, differences as well. When I was in Miami, we saw a lot more younger women with breast cancer. People from the Bahamas had a higher chance of developing breast cancer. We see in African American women, higher chance of getting triple negative breast cancer early on. So that kind of brings me to doing a self breast exam. So, mammograms are recommended at age 40 typically and to be done every year after that.
Hmm.
If you have a family history, let's say you had a family member who was diagnosed with breast cancer at 45, you want to get your mammogram 10 years before that. So that's 35. So you shouldn't be waiting till 40 because you're not average risk. Now
Hmm.
you have family history
Okay.
so you can get it early. We don't recommend mammograms before 30 because a lot of women have very dense breasts when they're young and it's not going to really show anything.
Hmm.
So typically we do mammograms after 30. And then if you have a significant family history and you're considered high risk, we can even do an MRI earlier on. So you don't have to start at 40. So really you should know a little bit of your family history
Hmm.
and then start testing at 40. Some women who are diagnosed, early with breast cancer, a lot of the times it was a lump that they felt. So it's also important to do a self breast exam, and
Yeah.
that's recommended, starting at the age of 20.
Okay.
So once a month, A good time to do it is after menses, because before you can have more
Hmm.
tenderness in the breast.
And what are some things that people should look out for when they're doing a self-exam?
Self-exam.
Yeah.
Yeah, so things to look out for, changes in the skin of your breast, changes in the nipple where, there could be some dimpling, pulling of the tissue, nipple discharge, a lump in the armpit. So those are the
So
main
they should
things.
check the armpit as well as the breast.
Exactly.
Okay. And how does RUMC integrate, screening, surgery, and recovery for patients?
We have primary care providers, we have GYNs. When patients are seeing their providers, they're getting their testing, the annual testing done. So they
Hmm.
go get their mammogram, they get their colonoscopy and all of those things. So when they get their imaging done, if there is a concern, we have navigators that are able to bring the patients to myself if there's a breast concern. And, if it's another site, they're able to navigate them to the appropriate provider. And then we have, I would see the patient. We would have a multidisciplinary tumor board. We discuss what's going on. We review the images, the pathology. We talk to the medical oncologist, the radiation oncologist, myself. We come up with a plan for this particular patient.
Okay.
If they need to have neoadjuvant therapy, as I mentioned earlier, treatment before surgery, they would see the oncologist, start treatment there, but they'll still follow up with me. And then we'll go for surgery. In some patients, we go for surgery first, and then they go for their adjuvant therapy later. So adjuvant therapy could be, endocrine therapy, chemotherapy, immunotherapy, and then radiation therapy. And when they're done with all that, during that period of time too, if there's reconstruction, we work with a plastic surgeon. So all of these providers are within our system.
Hmm.
They're able to be reached through the help of our navigators. We're always in communication because we have a tumor board where we discuss, how patients are doing. And then when they're done with their treatment, we have the survivorship plan where we follow up with the patients for about 5 years afterwards. So there's always going to be someone there for the next step, so they're not falling through the cracks.
That's great. And what would you say is unique about the approach RUMC takes compared to larger cancer centers in the city?
Yeah, so I think I love community hospitals because it really feels like they take each patient as a person. So you're not the next person and then move on to the next patient. So it's really we know each other. It's a small community. We all know each other. We speak to each other, very regularly. And we treat the patients the same way. When they come in, we're having a conversation. It's not like, well, this is your thing and, that's what we're going to do. We're having a conversation. We're talking about options and we're coming up with the best plan for everyone. So I think that's the difference. It's a community. It's a very tight-knit community. We are very much in touch with each other and we treat the patients like family.
One last question, just to bring in the men because we do know that men are at risk as well. How can men also be a part of breast cancer awareness, whether through self-checks or supporting the women in their lives?
Yeah, so breast cancer in men is rare, but it can happen.
Hmm.
So if there's a family history, you should be a little bit more aware. A lot of the times, they feel a lump and they come in and we start the process. So if you do feel a lump, don't wait.
Yeah. Of course. And I mean, I know you mentioned some changes in the skin or possibly a nipple
Right.
discharge, but, many people think that a lump is the only warning sign of breast cancer. Are there any other changes to be aware of? Maybe you can share like a top 5 signs or symptoms that women should watch, maybe beyond just finding a
Yeah.
lump.
So lump in the armpit, that's one.
Okay.
Because typically when they're doing a breast exam, they may not be thinking about the armpit,
Yeah.
but it can present there.
Mm-hmm.
A lump in the breast, skin changes like dimpling of the skin, like what I mean is like pulling of the
Mm-hmm.
skin, tethering of the skin, where the shape of the other breast you can always compare. This one looks different, where
Yeah.
it's getting pulled. You can sometimes see what's called peau d'orange. That that happens with inflammatory breast cancer. It's not that common. A lot of women come in worried that they have that, and
Yeah.
a lot of the times I have to reassure. But Potoron, just like an orange peel appearance of the breast, so that could be a sign of inflammatory cancer.
Okay.
Again, it's not that common, but redness, irritation, it's not really going away. A lot of the times it could be related to an abscess or an infection. Rarely can be associated with cancer. Nipple discharge can present, bloody nipple discharge. It's not a usual thing to see. So those are signs. And then nipple retraction. So the nipple is pulling in. So you're looking at your other nipple. Well, this one
Yeah.
doesn't look the same. It's pulling in. Something's going on.
Okay. And with October being Breast Cancer Awareness Month, what is one thing that you want our listeners to remember after this conversation?
Yeah, so it's very important to do screenings. Screenings should start at 40, 10 years before a family member that's been diagnosed, if they've been diagnosed early. This is what is going to help as far as having better survivorship, better treatment, easier treatment, and better long-term outcome. So earlier we catch cancer, the easier it is to treat, the easier it is to manage, and then we can move on. So that's the most important thing.
Wonderful. Well, thank you so much for joining me today. I really appreciate your time and your educating us through what life looks like after breast cancer surgery, from recovery and confidence to the innovations that are shaping our future. And, this Breast Cancer Awareness Month, let's all remember that early detection is key. So know your body, perform regular self-exams, schedule your mammograms. And if you'd like to schedule that, or, for more information about screenings, oncoplastic surgery, and the full range of breast health services available at Richmond University Medical Center, including consultations with Dr. Yoga, please call 718-818-1161 or visit www.rumcsi.org. You've been listening to RUMC Connections. I'm your host, Meredith Gaskins, and we'll be back soon with more conversations to keep our community informed and connected. Thank you.